Thank you, Professor Vlachos, and thank you all for the invitation today. So my presentation is going to be in the newer anticoagulants in the pediatric and dental congenital heart disease. The structure of my talk is going to be, I'm going to talk generally first about these new medications that as pediatric cardiologists, we don't know much about. They're used in the adult population, they're used in the adult congenital cardiology, their recent use in pediatric population generally, and what we know about their use in the pediatric cardiology population. Now, they have been in the market for quite a long time now, approximately 15 to 17 years that they were initially mentioned. However, the first approval from the FDA was for dabigatran, and it was in 2010. They are known as novel anticoagulants, so you can find them as NOAC or direct oral anticoagulants, DOAC. And currently, the randomized controlled trials that exist and that they give guidance, it is about adult patients with structurally normal hearts. And these patients do have acquired cardiovascular disease, and these medications have been proven definitely equal and never non-inferior in comparison to VKAs. VKAs is vitamin K antagonists for conditions like atrial arrhythmias, venous thrombotic episodes, and thromboprophylaxis. Which are those medications? Currently in the market, there are 5 of them. One of them is acting directly on inhibiting thrombin 2A, and that is dabigatran. And we have rivaroxaban, apixaban, edoxaban, and betrixaban that act in inhibiting factor 10A. These are the final steps before fibrinogen converts into fibrin. So these are quite later on in the cascade, and not like VKAs that they act quite early on in the production of the factors. What are the advantages over VKA? Loads. However, we have to be super vigilant about those ones. So we have fixed doses. And these doses are established according to renal function and the risk of intracardial bleeding. So as you understand, this is quite important, especially in little patients that they would require dose adjustments in regards to what the previous result of the monitoring system was. And in the elderly patients, that the renal function actually goes off as they age. Obviously, they're used in other cases that we're going to see later on, and we will see how these adjustments are made. They act quite rapidly, so their antithrombotic treatment starts very early. They have short half-lives, so easy to be stopped before a procedure or to change the medication. The patients in all the studies that I have seen, they're quite compliant, about 90% of them, and that is a very good sign. The pharmacological interactions are quite limited, which is again a very important step, as we all know that we were quite limited in the medications that we could provide in patients that they follow the conservative and the previous known treatment. They are, as I said, in more complex patients, for example, oncology patients that they use them, started using them, they're very easily manageable. And also in patients with heart failure that they use other medications as well. And in randomized controlled trials, they have shown a better safety profile than those ones that they are the vitamin K inhibitors. I have this slide here is quite busy. However, it shows the major indications that the newer anticoagulants have taken approval, they are approved for. However, they're used for other conditions as well. As you can see, the majority of them, they are for prevention of venous thromboembolism, especially in patients that they have undergone orthopedic surgeries like hip and knee replacement, and to provoke stroke in systemic embolism in adults that they have suffered from AF, and they have other risk factors as well. Also, for treatment of deep vein thrombosis and pulmonary embolism, as well as the prevention of recurrency. Rivaroxaban, which is the first one in the column, also has been approved for co-administration with aspirin or aspirin and clopidogrel in prevention of atherothrombotic events after a first episode of acute coronary artery syndrome with elevated biomarkers. And obviously, as I mentioned previously, there are other uses of those medications that they have not necessarily been approved formally. However, their use in the oncology patients is increasing significantly. We can all understand why. Looking at the pharmacokinetics of these ones, of the new anticoagulants, we can see that time to maximum effect is very short, so they are short acting. Half-lives are short, and what we need to pay attention to is the elimination, which is further down at the bottom of the table. So dabigatran is the only one that in the majority of it is metabolized in the kidneys. Therefore, it needs specific attention. So these patients that they have to be started on the dabigatran, they have to have their renal function checked first. Rivaroxaban, apixaban, and doxaban, they are excreted by the kidneys. However, they are metabolized in a significant degree in the liver. And the patients that they need to undergo and be prescribed with those medications, we have to make sure that they have optimal liver function. Obviously, there are interactions with other drugs. They are mentioned on this table. And the good thing is that there are not that many food-drug interactions. And the other thing is that we have to pay attention is to the dosages. Again, we need to refer to each one of them specifically because for the dosing system, because for different indications, they have two different dosing systems. What are the contraindications of prescribing newer anticoagulants in the adult patients? First of all, mechanical heart valves. There was a study that was abandoned. This was the REALIGN study, which actually was investigating the action of dabigatran versus warfarin. And it was early terminated because of excessive thromboembolic and bleeding events. So if you see all the studies up until then, that they are currently being conducted, they exclude the patients with mechanical heart valves. Pregnancy and lactation, I think we all understand why. Patients that they suffer from antiphospholipid syndrome, they have positive lupus anticoagulant and anticardiolipin antibodies are again advised not to be started on those medications at the moment. At the moment, there are studies going on with in regards to those patients and the newer anticoagulants. Patients with excessive body weight, again, they're not advised to be started on newer anticoagulants. It's not contraindicated, however, the advice is not to, because the volume of distribution is quite significant, and we don't know exactly the dosages, the accurate dosages, and what the outcome is in those patients, and of course in patients with renal impairment. This is a small table which summarized all that I have mentioned previously, and it can serve as a take-home message if you want a quick reference about how they act, what are the indications, dose frequency, and the renal adjustments or contraindications if required. What happens now in the adult congenital heart disease and the newer anticoagulants? I will refer into two major studies and publications that are out there. This one that I'm showing here is the one that was published early in 2020, and this is the NOTE registry. The NOTE registry is a registry that was created by the Adult Congenital Heart Association for adults, to register the adults that they are on oral anticoagulants. And it involves 500, up until the publication, it involved 530 patients that the mean age of them was 47 years old. The majority of those patients had moderate to severe congenital heart issues, meaning residual shunts, bioprostatic valves, frontal circulation, Eisenmenger, and cyanotic patients. The primary efficacy endpoint was thromboembolism, another ischemic cerebrovascular accident, and transient ischemic attacks, or another thrombus formation within the heart. The primary safety endpoint was major bleeding, and secondary endpoints include minor bleeding events that they were recorded. Basically, this study was designed to address the safety of the newer anticoagulants in congenital heart disease, in adults with congenital heart disease. It was not a comparison, it was just a registry. And what they found was, over a median follow-up of about 1 year, the thromboembolic events were pretty similar to the patients that they were receiving conventional treatment. And again, the major bleeding events were not more than, again, the patients that they were receiving conventional treatment. So the adherence to the treatment was quite good, about 80 to 93%. And the quality of life had improved because these medications do not require monitoring. So basically what they concluded was that the newer anticoagulants in adults with congenital heart disease are safe and not inferior to be used in adult congenital heart disease in comparison to the other treatment that has been used up until now. A little bit later on, during 2020, another study in adult congenital heart disease and the use of newer anticoagulants was published. This was a German study. Again, this patient cohort was much more significant. There were 44,000 patients, adults, that they were studied between 2005 and 2018. And this was based that adult congenital heart disease patients have an increased fold of elevated thromboembolic complication risks when compared to the normal adult cohorts. And many of those ones will require long-term oral anticoagulation at some point in their lives. Therefore, they wanted to see what the thromboembolic effect and bleeding rates and side effects of the population is in comparison to the other patients in the registry that they are taking conventional treatment. So the results of this study are contradicting the results of the previous one. However, there are differences in the population. So in this study, there were higher thromboembolic events, bleeding rates, overall mortality, and the MACE was higher after 1 year of therapy compared to the conventional treatment. And approximately half of the patients in that registry were prescribed anticoagulants during that period of time. Therefore, looking at this adjusted outcome for adult congenital heart disease with patients with vitamin K antagonists or novel anticoagulants, the results are time-dependent, and the Cox regression analysis here illustrates the association between the oral anticoagulants and the vitamin K antagonists and the study endpoints, as was mentioned previously. So for bleeding, major bleeding, intracardiac bleeding, and thromboembolic and major thromboembolic events, death was considered a competing event, and the cause-specific hazard ratios are presented here. What we can see is that what favors the novel anticoagulants is intracerebral hemorrhage. They have proven to have less events in patients that they were taking the newer anticoagulants in comparison to those ones that they were taking the conventional treatment. However, following that, the authors concluded that the newer anticoagulants should not be used in adult congenital patients yet, since they are not concise guidelines. We need more prospective studies before solid recommendations for those patients can be provided. Now, a few words about the Fontan patients. Again, here I'm referring to adult patients with Fontan circulation. There was a study that was published in 2019 from the States. And what they have shown is taking again the patients from the NOTE registry, about 74 patients with Fontan circulation and a range of age of 18 to 68. What they have shown is that these patients have looking at the Kaplan-Meier curves, the survival free from thromboembolic event, major bleeding and minor bleeding are equally good, if not better, in those patients that they are receiving the novel anticoagulants. And when they have swapped from the previous treatment to the newer ones, it shows again favorable results, and they are free from thromboembolism and major bleeding for quite a long time. Therefore, what they have suggested is that they are well tolerated, and the newer drugs, their efficiency and safety during short-term follow-up seems to be equally good and safe in use in patients with Fontan circulation. However, longer-term data are required to confirm those early results. Moving on to children now, what we know is that the incidence of vascular thrombotic events in children and adolescents has increased, mainly for two reasons. We are doing more invasive procedures and invasive diagnostic procedures as well. This, of course, interrupts the vascular anatomy, and it is a cause for thrombus. And The other issue is that in adolescents, there is increasing use of oral contraceptives, which again is a prothrombotic issue. Currently, we use the conventional methods most commonly, like unfractionated heparin, low molecular weight heparin, and vitamin K antagonists. And problems with those medications at the pediatric population are unpredictable pharmacokinetic response. So we know that it's very difficult to control INR occasionally. Several drug-informed interactions, need for parenteral administration and frequent monitoring, having to do bloods all the time, problematic in children with poor venous access that they cannot have parenteral administration of those medications, and that needs again to another catheter placement for that, which increases the thromboembolic risk. There are two populations, there are two studies in the pediatric population, one the Einstein Jr. and the Kids Dot. These are randomized control trials. The first of all, it involved patients from day 1 to 17 years old, and it involves rivaroxaban against the current parenteral therapy. Most patients were treated for more than 3 months, and patients younger than 2 years with line thrombosis were treated only for 1 month. There was no significant difference between the treatment groups in efficacy and the safety outcomes, and no treatment-related deaths, so it was quite a safe study. And the recurrency of the thromboembolic events was lower in the rivaroxaban group. So the outcome was that rivaroxaban is similarly efficacious and safe in children as it is in adults. However, before the rivaroxaban was started in those children, we have to mention that they were conventionally treated for between 5 and 9 days. Similar results from the other randomized control trial in children, but this one involved a slightly older children, so 3 months to 18 years old. Again, with a history with provoked VTE, and this was for dabigatran over the conventional treatment for a duration of 8 months. The results were similar, therefore dabigatran was proven to be safe to be used in children. Issues with those studies. They didn't define the optimal duration for anticoagulant therapy on those patients, so we don't know for how long we should treat them. The relationship between antiphospholipid antibodies, as I mentioned previously, and outcomes is not well defined, and we don't know what to do with those patients. And of course, the role of the newer anticoagulants as primary thromboprophylaxis in hospitalized children has not been clear, and we don't know if it is safe to do so, and what is the optimal dose that we need to prescribe the newer anticoagulants. At the moment, there are multiple clinical trials evaluating the efficiency of the newer anticoagulants in pediatric populations. We know a study for apixaban and edoxaban. They are multi-center studies, open label, and they involve children up to 17 years old. So in the apixaban trial, which is quite important, the outcome of this, whenever it comes out, the participants will be randomized without initial parenteral treatment which is completely different from the 2 ones that they have been published up to now. And the betrixaban, which is the newer NOAC that has been come to the market, they are not undergoing any open pediatric trials at the moment. What we know about the pediatric congenital heart disease population, we don't have special studies published for this population, which is our basically our interest on. Only 12 out of 200 children were having congenital heart disease problems, and these were minor in the Kids trial, so very limited number. The are children, including in some observational registries. However, the population is very limited, and there are only recommendations and expert opinions and no clear guidance. However, the saxophone trial, which is a randomized control trial for apixaban versus the current treatment that we are using in congenital heart disease, is undergoing as we speak. The results are still awaited with great interest. To summarize, in adults with congenital heart disease and the use of newer anticoagulants, most likely they are safe to use. We are waiting for more information, and from our practice at the Evelina and St. Thomas's Hospital, the adult population with congenital heart disease have been switched and swapped quite a significant number of them to the newer anticoagulants, however, under close monitoring and in continuous discussion with the hematology team. And of course, there is the contraindication that we cannot use patients, the newer anticoagulants in patients with mechanical valves, which is a quite limiting factor. In children, rivaroxaban is used.
Παρασκευή, συγγνώμη για τη διακοπή. Έχουμε θέμα με το χρόνο. Αν μπορούσες...
This is the last slide.
Ειδοποιεί το control, συγγνώμη. Ναι.
No problem. This is the last one. Rivaroxaban is used in the secondary prophylaxis after 5 days of parenteral medication from the neonatal age. That is the current practice. The Bigatran the same. However, we're not using it in children less than 8 years old. And we are awaiting the results of the randomized control trial, and we cannot use them for primary thrombus prevention in the pediatric population. And thank you for your patience.
Ευχαριστούμε πάρα πολύ, κυρία Θεοχάρη, για την πολύ λεπτομερή και εμπεριστατωμένη ομιλία σας. Τίθενται πάρα πολλά θέματα. Δυστυχώς δεν έχουμε χρόνο, γιατί έχουμε ξεφύγει λιγάκι. Θέλω και πάλι να σας ευχαριστήσω. Να ευχαριστήσω και όλους τους παρακολουθήσαντες και παρακολουθούντες το session αυτό. Και να δώσω τον λόγο στην κυρία Γιαννακοπούλου και στον κύριο Βλάχο για να κλείσουμε το session.
Όπως είπατε, ήταν και κάθε ομιλία θα μπορούσε να αποτελεί ένα ξεχωριστό σεμινάριο, ας πούμε, για να συζητήσουμε εδώ. Και υπήρχαν και πολλές ερωτήσεις. Ευχαριστώ για την υπομονή όλους και τις ωραίες ομιλίες των ομιλητών. Είστε όλοι υπέροχοι. Ευχαριστώ πάρα πολύ.